Jaundice in the Biliary Tract, written and narrated by Dr.Boyd. The gallbladder is a pear-shaped organ in the right upper quadrant of the abdomen. It measures approximately 7 to 10 centimeters in length and 4 centimeters in width. The gallbladder fundus is wide, and as it continues into the main body, it narrows in diameter. The gallbladder body tapers into the infundibulum, which connects to the neck and the cystic duct. At the distal portion of the gallbladder and into the cystic duct are the spiral valves of Heister, preventing reflux of bile into the gallbladder. The gallbladder receives most of its blood supply from the cystic artery. The cystic artery is a branch of the right hepatic artery that arises from the common hepatic artery. The cystic duct joins the common hepatic duct after exiting the gallbladder to form the common bile duct. The pancreatic duct forms a distal end of the common bile duct to form the common channel known as the ampulla of Vater. The ampulla of Vater is surrounded by a smooth muscle called the sphincter of Oddi, which prevents reflux of duodenal secretions into the bile duct. The Phrygian cap is a congenital anomaly where the fundus of the gallbladder folds back onto itself, resembling the Phrygian cap, a soft conical hat of the Mediterranean sailors. A Phrygian cap is typically benign and asymptomatic. If symptomatic, cholecystectomy is indicated. The liver produces 500 to 1,500 milliliters of bile per day. Bile contains bile salts, lecithin, fatty acids, and bilirubin. The bile acids are cholic and deoxycholic acid and are breakdown products of cholesterol. In the hepatocyte, they are conjugated with taurine and glycine to become bile salts. Bile salts emulsify fat and aid in the absorption of fat and the fat-soluble vitamins A, E, D, and K. Bile flows through the common hepatic duct and then the cystic duct into the gallbladder, where it's concentrated and stored between meals. Factors that regulate bile flow are hepatic secretion, gallbladder contraction, and common bile duct sphincteric resistance. When stimulated by the hormone cholecystokinin, the gallbladder contracts, pushing bile through the cystic duct and into the common duct. Simultaneously, the sphincter of Oddi relaxes, permitting bile to enter the duodenal lumen. In the small intestine, bile acids facilitate lipid digestion and absorption. Bilirubin is a product of the breakdown of hemoglobin. Approximately 100 to 200 million RBCs are broken down every hour. Degradation of hemoglobin begins in the liver, spleen, bone marrow, and skin. Hemoglobin is degraded to globins, which are further broken down into amino acids. The iron is transported with transferrin and used in the next heme biosynthesis. Heme is converted to biliverdin and then into bilirubin. Bilirubin is then conjugated with glucuronic acid. The water-soluble conjugated bilirubin is then secreted into bile, providing the characteristic yellow color. In the small intestine, bacteria form secondary bile acids via dehydroxylation of primary bile acids. Bacteria converts bilirubin to urobilinogen. In the colon, urobilin and stercobilin are oxidized from urobilinogen and are responsible for the dark fecal pigment. Jaundice may result from prehepatic causes, where there's an excess production of bilirubin that overtakes the liver's capacity to conjugate the bilirubin. This causes predominantly unconjugated hyperbilirubinemia. Excess heme breakdown, as in hemolytic anemia, is a common cause. Intrahepatic causes are due to parenchymal liver disease with the inability to either conjugate or excrete bilirubin. In this case, the fraction of bilirubin that is conjugated varies. Viral hepatitis often has a predominantly unconjugated hyperbilirubinemia. A conjugated hyperbilirubinemia is seen with cholestasis from drugs or primary biliary cholangitis. In posthepatic jaundice or obstructive jaundice, there is an impediment to flow of bile due to partial or complete obstruction of the extrahepatic biliary passage between the liver and the duodenum. This is predominantly a conjugated hyperbilirubinemia. There is an associated increase in alkaline phosphatase. The three types are demonstrated here. Non-obstructive jaundice is seen in alcoholic liver disease, hepatitis, absorption of large hematomas, as well as congenital defects in hemoglobin metabolism such as Gilbert syndrome, Crigler-Najjar syndrome, and Dubin-Johnson syndrome. A cause of non-obstructive jaundice that is too common today is non-alcoholic liver disease or fatty liver, which can become non-alcoholic steatohepatitis. This condition accounts for a high percentage of liver transplants today. When the amount of cholesterol in bile exceeds the holding capacity of the phospholipid lecithin vesicles, cholesterol crystals form. These crystals grow in the gallbladder to become visible gallstones. 75% of gallstones are cholesterol stones. Calcium bilirubinate or pigmented stones are seen in hereditary spherocytosis and sickle cell disease. Although most individuals with gallstones are asymptomatic, about 10% may develop symptoms within 5 years, and 20% within 20 years of diagnosis. The prevalence of gallstones increases with age. More than 25% of women older than 60 have gallstones. The often quoted 5 F's of gallbladder disease are fat, fair, female, 40, and flatulent. However, diet, pregnancy, Crohn's disease, sickle cell disease, and ileal resection are also risk factors. The complications of gallstones include acute cholecystitis, chronic cholecystitis, common bile duct obstruction, cholangitis, and gallstone ileus. Also, the second most common cause of acute pancreatitis is due to gallstones. Biliary pancreatitis is the second most common cause of pancreatitis and seen when stones become impacted distally in the ampulla, temporarily obstructing both the pancreatic and biliary ducts. The stones often pass spontaneously, producing a mild and transitory episode of cholangitis, along with the classic manifestations of pancreatitis, abdominal pain with elevated lipase and amylase. Sonogram confirms gallstones in the gallbladder. Conservative treatment, NPO, NG suction, IV fluids, usually leads to improvement, allowing elective cholecystectomy to be done at a later time. If not, ERCP and sphincterotomy may be required to dislodge the impacted stone. 15% of gallstones are radio-opaque and can be seen on plain films, while air in the gallbladder wall on plain films indicates emphysematous cholecystitis. Ultrasound is the preferred diagnostic modality for detecting gallstones. It has a very high sensitivity and specificity. Endoscopic retrograde cannulation of the pancreatic duct, or ERCP, is used to evaluate the possibility of common bile duct obstruction in the jaundice patient. Magnetic resonance cholangiopancreatography is non-invasive and equally as accurate. The hepatobiliary immunodiacetic acid, or HIDA scan, is a diagnostic nuclear medicine procedure which uses radio tracers to evaluate the biliary system. In the case of acute cholecystitis, which is largely caused by obstruction of the cystic duct, radio tracers cannot enter the gallbladder, which is demonstrated by the gallbladder non-visualization. In cases of chronic cholecystitis or biliary dyskinesia, there is a decreased ejection fraction measured objectively with maximum gallbladder radio tracer signal and minimum radio tracer signal after administration of a synthetic cholecystinin, which causes the gallbladder to contract. An ejection fraction of less than 35% indicates biliary dyskinesia. Asymptomatic gallstones. Each year, 2 to 4% of patients with asymptomatic gallstones will develop symptoms. Watchful waiting is generally indicated. However, certain patients may benefit from early cholecystectomy, such as those with hemolytic anemia, porcelain gallbladder, very large stones, or a young age. Biliary colic and chronic cholecystitis. Biliary colic occurs when a stone temporarily occludes the cystic duct. There's colicky pain in the right upper quadrant, radiating to the right shoulder, often triggered by ingestion of fatty food, and usually accompanied by nausea and vomiting, but without signs of peritoneal irritation or systemic signs of an inflammatory process. The episode is self-limited, maybe 20 to 30 minutes. If sonogram establishes diagnosis of gallstones, elective planned cholecystectomy is indicated. Chronic cholecystitis is inflammation of the gallbladder with the associated symptoms plus fever, tenderness, and persistent pain. Antibiotics and scheduled surgery is the treatment. Acute cholecystitis starts as biliary colic, but the stone remains in the cystic duct until an inflammatory process develops in the obstructed gallbladder. The pain becomes constant. There's modest fever and leukocytosis, and physical findings of peritoneal irritation in the right upper quadrant, with a positive Murphy sign, subcostal right upper quadrant pain elicited by palpation during inspiration. The sonogram is diagnostic and in most cases shows gallstones, a thick-walled gallbladder, and pericholecystic fluid. NG suction, NPO, IV fluids, and antibiotics are used to cool down most cases, allowing for elective cholecystectomy to follow. Physicians typically endeavor to do it in the same hospital admission as an urgent case, though it's not in the middle of the night true emergency. Empyema of the gallbladder is the most severe form of acute cholecystitis. Empyema of the gallbladder is usually the result of a progression of acute cholecystitis in a background of bile stasis and cystic duct obstruction. The stagnant bile in the gallbladder has superinfection with microorganisms that lead to separation in acutely inflamed gallbladder. Hence, the gallbladder lumen becomes filled with exudated material and very often frank pus. The treatment is antibiotics and emergency surgery. Emphysematous cholecystitis is a fulminant variety of acute cholecystitis. The characteristic feature of this variant of cholecystitis is the presence of gas in the lumen of the wall of the gallbladder. This fulminant form of cholecystitis has been reported to be more common in older patients who have diabetes mellitus. The prevalence of emphysematous cholecystitis is 3 times higher in men compared to women. There's also an association between peripheral vascular disease and immunosuppression. The mortality due to this life-threatening form of cholecystitis is reported to be 15 to 25%. Microorganisms have been isolated in patients with emphysematous cholecystitis include Clostridia, Klebsiella, E. coli, Enterococcus, and anaerobic strep. Treatment is emergency cholecystectomy and broad-spectrum antibiotics. Moritzi syndrome is a very rare condition caused by the obstruction of the common bile duct or common hepatic duct by external compression from multiple impacted gallstones or a single large impacted gallstone in Hartmann's pouch or the cystic duct, causing obstructive jaundice. Cholesterolosis is an acquired histologic abnormality of the gallbladder epithelium characterized by excessive accumulation of cholesterol esters and triglycerides within the epithelial macrophages. The combination of these deposits with mucosal hyperemia gives the appearance of a strawberry gallbladder macroscopically. This is usually diagnosed postoperatively. Biliary dyskinesia is a motility disorder that affects the gallbladder and the sphincter of Oddi. Patients with this condition present with biliary-type pain, and investigations show no evidence of gallstones in the gallbladder. A HIDA-scan ejection fraction of less than 35% is diagnostic, and the treatment is laparoscopic cholecystectomy. Cholecystoenteric fistula and gallstone ileus. Cholecystoenteric fistula is an anomalous communicating tract between the gallbladder and any segment of the gastrointestinal tract, most commonly the duodenum. The gallstone can pass into the GI tract, causing small bowel obstruction, gallstone ileus, or even colonic obstruction. Classically, cholecystoenteric fistulae are definitively managed by open surgery. with cholecystectomy, excision of the fistula, enterolithotomy if an obstructing stone is present, common bile duct exploration, open cholangiography, and reconstruction of the penetrated organ. Gallbladder carcinoma is a rare malignancy but represents 50% of all biliary tract cancers. Most tumors, about 90%, are adenocarcinomas. Gallbladder neoplasms are more prevalent in women. Metastasis is to the common duct lymph nodes and directly into the liver bed. For tumors localized to the gallbladder, the 5-year survival rate is 100%. But with regional disease, 5-year survival rate is 28%, and with distant metastasis, less than 5%. For those critically ill patients with acute cholecystitis, percutaneous cholecystostomy under ultrasonographic guidance is a cost-effective, easy-to-perform, and reliable procedure with low complication rates and high success rates. It's generally followed by elective cholecystectomy if possible. However, it may be the definitive treatment, especially in acalculous cholecystitis. The presence of stones within the common duct, choledocholithiasis, occurs in up to 15% of patients with gallstones. Conjugated hyperbilirubinemia and an elevated alkaline phosphatase is characteristics of those. Right upper quadrant ultrasound followed by ERCP to clear the duct, and then cholecystectomy is the treatment of choice. Cholangitis is always associated with biliary obstruction. The 3 most common causes, choledocholithiasis, common bile duct stricture, and neoplasm, stone, stricture, and tumor. Acute ascending cholangitis is a serious disease in which stones have reached the common duct, producing partial or complete obstruction and ascending infection. Patients are often older and much sicker. There's right upper quadrant pain with temperature spikes to 104 to 105 and jaundice. Pain, fever, and jaundice, Charcot's triad. Systemic sepsis can occur, resulting in confusion and hypotension. This is termed Reynolds pentad. There's predominantly conjugated hyperbilirubinemia and extremely high levels of alkaline phosphatase. Gut organisms are usually the infectious agent. Intravenous antibiotics and emergency decompression of the common duct, ideally by ERCP, alternatively percutaneously through the liver by percutaneous transhepatic cholangiogram, or rarely by surgery, are life-saving. Eventually, cholecystectomy must follow. Obstructive jaundice can also be caused by tumor. Cancer in the head of the pancreas can cause slow obstruction of the common bile duct, resulting in painless jaundice and a palpable dilated gallbladder called Courvoisier's sign. Tumor of the confluence of the hepatic ducts are called cholangiocarcinoma or Claskin's tumor. Primary sclerosing cholangitis. Primary sclerosing cholangitis is a slowly evolving onion skin-like fibrosis and inflammation around the extrahepatic ducts that sometimes include the intrahepatic ducts. It's associated with ulcerative colitis and can cause ductal obstruction with cholangitis. There is no effective treatment other than transplant. Caroli syndrome is a rare congenital condition characterized by segmental dilatation of large intrahepatic bile ducts. It's autosomal recessive and associated with polycystic kidney disease. Hepatic fibrosis and portal hypertension occurs. The only treatment for multilobular disease is transplantation. Hepatic tumors. Hepatic adenoma is a rare benign epithelial liver tumor frequently associated with oral contraceptive pill intake. The lesion enhances on the arterial phase. Hepatic adenomas are benign, but carry a risk of hemorrhage and malignant transformation. Elective resection is recommended in all men with adenomas of any size and in women with tumors larger than 5 centimeters. Focal nodular hyperplasia, a benign liver lesion that's composed of a proliferation of hyperplastic hepatocytes surrounding a central stellate scar. FNH is the second most common benign hepatic lesion, accounting for approximately 8% of all non-hemangiomatous liver lesions. Typically, FNH is a solitary lesion that is more commonly seen in females. Close observation is recommended with serial imaging every 3 to 6 months. However, biopsy or resection is pursued if a patient is symptomatic, if there is concern for an underlying malignancy after an inconclusive biopsy, or if a lesion displays continued growth. The definitive therapy remains surgical resection. Angiomas of the liver look solid on ultrasound, but with contrast injection, there's a slow filling of the lesion from the periphery. These are congenital vascular malformations and are the most common benign masses of the liver. They rarely rupture or spontaneously bleed, and they have no malignant potential. Biopsy should be avoided because of the risk of iatrogenic bleeding. Most patients with hemangiomas remain asymptomatic and require no intervention. The most common type of primary liver cancer in adults is hepatocellular carcinoma. Hepatocellular carcinoma is the third leading cause of cancer-related deaths worldwide. The development of hepatocellular carcinoma is attributed to fibrosis and cirrhosis. It occurs primarily in underlying liver disease of cirrhosis and hepatitis, but 25% have no risk factors. With contrast CT, the tumor enhances in the arterial phase, and the contrast is washed out by the portal circulation in the venous phase. The specific blood marker is alpha-fetoprotein. 15% of these tumors are completely resectable. Otherwise, there's a 3 to 6 month survival. And overall, the 5-year survival is 18%. Metastatic cancer of the liver outnumbers primary cancer of the liver in the United States by 20 to 1. Colon, pancreatic, and breast cancers are the most common. It is found by CT scan and follow-up for the treated primary tumor is suspected because of a rising CEA level in those with colonic cancer, for example. If the primary is slow growing and the metastases are confined to one lobe, lobectomy resection can be done. Other means of control include radioablation. And most will receive chemotherapy. The overall 5-year survival is 15%. Jaundice in the Biliary Tract, written and narrated by Dr.Boyd.